One, please start, sir. We are live.
Good evening, friends. Welcome to the PG Track program of Delhi CSI, 82nd webinar. Consistently, we have been presenting variety of topics with different speakers across the country and bringing you the best in cardiology, especially the clinics for all our residents, our fellows, and our colleagues. So, from today onwards, we are innovating and starting a new series of rapid fires in cardiology. So why rapid fires in cardiology? Because often there are certain topics that don't deserve a whole session actually, but they are very commonly asked. They are very important for our clinical practice, and they are also important for our exam. So today in this series, we have our young and dynamic speaker, Dr. Satyaveer Yadav, who has joined us from All India Institute of Medical Sciences. He's assistant professor of cardiology there. On this journey, I have my colleagues, Professor Girish MP and Professor Sumod Kurian from GB Pant Hospital, Delhi. And we welcome Dr. Satyaveer. He'll be speaking on hemodynamics of the pericardial diseases. The second topic that he'll be speaking is on cyanotic spell. The third one is natriuretic peptides in valvular arrays. My humble request to all our fellows, our colleagues who have joined across the Zoom as well as all the platform and the YouTube, in case you require certain important topics to be covered as rapid fires or as detailed lectures, please message me personally or mail it to us on the pgtraxcs@delhibranch@gmail.com, and we'll be happy to include them according to their clinical relevance into our subsequent lectures and with your speaker recommendations, or we'll choose the best guys across for you. So I also thank Intas for providing us this platform. So over to you, Satyaveer. Welcome for joining us in this first series, and thank you so much for sparing your time. Over to you, sir.
Thank you very much, sir, for your kind words. A very good evening to all esteemed panelists. I would also like to thank Delhi CSI for giving me an opportunity to present in this unique PG Track program webinar. Today, I'll be discussing about hemodynamics of pericardial disease, cyanotic spell, and natriuretic peptide in valvular aortic stenosis. So without wasting much time, I'll come to my first topic, which is pathophysiology and hemodynamics of pericardial diseases. So pericardium basically is a fibroserous sac, and it is situated between the visceral and parietal layer of the serous pericardium, and it contains less than 50 ml of serous fluid. So is pericardium really necessary? As we all know that nature has made nothing without reason. So pericardium has three important functions. One is to maintain the position of heart, and another is to provide lubrication. So it acts as a barrier to inflammation and infection. And another one is to limit the excess acute chamber dilation of heart. So first pathology is pericardial effusion and tamponade. So before we understand the pathophysiology of tamponade, there are two important things which we need to understand. One is pericardial reserve volume, and another is pericardial constraint. So pericardial reserve volume is a volume beyond which there is a steep increase in the pressure. Whenever there is accumulation of fluid in the pericardium, at certain level, pressure, after a certain level, pressure increases steeply. So that volume is known as pericardial reserve volume, and constraint is the resistance offered by pericardium beyond the pericardial reserve volume. So this reserve volume actually differs on the rapidity of fluid accumulation. When there is acute fluid accumulation, this pericardial reserve volume is small. So that's why tamponade occurs very early in acute accumulation of fluid. Sometimes like in traumatic injury to heart, even 50 to 100 ml accumulation of fluid can cause tamponade. While in chronic fluid accumulation in the infective pathology, the pericardial reserve volume is increased due to the compensatory mechanisms. That's why tamponade occurs very late. Even 500 or 1000 ml of fluid may not cause tamponade. So what happens in pericardial effusion? Increased intrapericardial pressure leads to decreased filling, which further leads to decreased stroke volume and decreased arterial pressures. And these things lead to compensatory adrenergic stimulation, which leads to increased heart rate and increased systemic vascular resistance. So that I have shown you in the previous slide that pericardial reserve volume differs in both acute and chronic fluid accumulation. one important thing is the last drop effect. Means when the limit of pericardial reserve volume is reached, even small amount of fluid accumulation leads to tamponade. While same occurs when we perform the pericardiocentesis. When we do pericardiocentesis, the initial first decrement during the drainage causes the largest decompression to the heart, and the symptoms improvement immediately occurs. So I have kept some questions for the fellows. So my first question is, what is the characteristic pattern of JVP, which is a very important question frequently asked during the exams. So what is the characteristic pattern of JVP and tamponade? So for that, I'll show you the normal JVP trace. So in normal JVP trace, there are two positive waves, A and V, and two major negative waves, X and Y descents. So what happens in the tamponade, that X descent is preserved, but Y descent is blunted. And why Y descent is blunted? Because Y descent predominantly occurs during the diastole, and the impedance to the flow in the cardiac chambers occurs throughout the diastole in the tamponade. That's why the Y descent is blunted in the jugular venous pressure in tamponade. My next question is, when does atrium collapse? When earliest in the tamponade. So I'll come to the answer by my slides. And when does ventricle collapse in the tamponade? So both timing are very important, because when we perform echocardiography for diagnosis of tamponade, it's very important to see the timing of both chambers collapse. So right atrial collapse basically starts at the end of diastole, and it persists in the early phase of systole. And its duration is very important for diagnosis of tamponade. If it's persisting more than 1/3 of cardiac cycle, then it's 100% specific for tamponade. There are certain conditions when we have already high right atrial pressures, like RA hypertension or ventricular pacing, where we can miss this specific and sensitive feature of tamponade. So apart from right atrial collapse, so this is this slide showing the echo images of the right atrial collapse. On the left panel, there is arrow which is showing the indentation in the right atrial wall. And on the right side, the M mode image, which is showing the RA free wall collapse. And this collapse is basically occurring near the end of diastole and the start of systole. So apart from right atrium collapse, right ventricle collapse also occur, and it starts at the early diastole. And in the ECG, early diastole is at the end of T wave. So it's most evident in the expiration, because on the in the expiration, right-sided pressure fall occurs more in the expiration, and it is associated with the significant reduction in the cardiac output. Right ventricle collapse is more specific indicator than right atrium collapse, and if it's present, it means the tamponade is severe. And there are certain conditions, like if pulmonary artery pressures are already increased or patient is in the condition of volume overload, then we might not observe the right ventricle collapse. So in the left panel, we see the parasternal long axis image, and the right ventricle collapse is seen. And on the right panel, the RV collapse is seen. And in the above, we can see the ECG, and we can compare the RV collapse that it's occurring during the early diastole. So although right chambers collapse occur more common in the tamponade, left heart chamber collapse may also be seen, which is less common than the right-sided chambers. But when it is found, it means it's very specific for the tamponade. And only chamber collapsing in the pulmonary hypertension and regional tamponade. LV chamber collapse we may also observe, but that's occur only in the regional or localized diffusion only. So apart from chamber collapse, there is disturbance in the systemic venous return also, which can be appreciated by hepatic vein Doppler. So to understand that, we have to understand the normal hepatic vein Doppler. So on the left panel, there is normal hepatic vein Doppler. So hepatic vein Doppler has 4 waves. So A, V, and S and D. So it starts with A. So A is basically denotes atrial contraction. And there are 2 forward velocity wave. One is S occurs during systole, which is greater than the D. D occurs during the diastole. And there is a indentation in between, which is V wave. So this is the normal hepatic vein Doppler, which we are seeing on the left side of the panel. So the difference in the tamponade is mainly in the diastolic velocity. So there will be a reversal of diastolic flow, and it's different from the normal because the atrial in the normal hepatic vein Doppler, that reversal wave is occurring due to atrial contraction, while the reversal of flow occurring before the atrial contraction in the cardiac tamponade, which we can see with the comparison of ECG also, that this diastolic reversal occurring prior to peak of R wave and end of T wave. So this is occurring predominantly in the diastole. So this is the main difference in the hepatic vein Doppler. So apart from these chamber collapse and systemic venous return, there is respiratory variation in left and right chamber filling also, because there is exaggerated ventricular interdependence. Ventricular interdependence occurs in normal heart also, but that is up to a certain limit. But when it limit crosses, there is increased ventricular interdependence, which is due to increased pericardial pressure. So due to increased intrapericardial pressure, normally during inspiration intrapericardial pressure falls, but due to large pericardial effusion or tamponade, this intrapericardial pressure does not fall in the inspiration. So this leads to the increased ventricular interdependence, and this increased ventricular interdependence during inspiration causes increased RV diastolic diameter and decreased LV diastolic diameter. And this can be appreciated in the echo by looking at the pulse wave Doppler of the inflow and outflow. So what happens in normal inflow is that there is a reduction in the mitral velocity during inspiration. Means left-sided chambers flow is decreased during inspiration, while right-sided chambers flow is increased during the inspiration. But this reduction is limited to certain extent, like in left-sided it's limited to 10 to 15%, and on the right side it's less than 30%. While in the cardiac tamponade, the reduction is more than 25% in the mitral valve, while in tricuspid valve, the drop is more than 40%. As we all know that due to these enhanced chamber interaction, there is increased diastolic pressure in all chambers, and all chambers diastolic pressure is equalizes. Pulmonary vein, because it's a extrapericardial structures, that's why the pressure in pulmonary vein remains different than the intracardiac pressures. So this is a pulse wave Doppler image at the tricuspid inflow and mitral inflow. To better appreciate these respiratory variation, we have to keep the cursor's speed very slow. So in the left panel, as we can see, that tricuspid inflow is having more than 40% variation, while in the mitral inflow, the inflow is decreasing during the inspiration and increasing during the expiration. And this reduction is more than 25%, which is quite specific for the tamponade. And apart from that, we can observe ventricular interdependence on M mode also by looking at the septal shift. So septum is shifted towards the left ventricle, and this is the paradoxical movement of interventricular septum in the early diastole. Apart from these, we can have increased pulmonary artery pressure in tamponade, but the pressure increase in the pressure is not more than 50 or 55 mm of Hg. And apart from these, aortic pressure and velocity also decreases in the inspiration, because any left inflow and outflow both decreases during the inspiration and increases during the expiration. And plethora of IVC is quite sensitive marker of tamponade, but it's not very specific, because most of the time, whenever there is elevation of the systemic venous pressure, this IVC plethora will be there. And IVC diameter will be more than 21 millimeter and its collapse will be less than 50%. So these are the various echocardiographic signs with variable sensitivity. So if we observe collapse of both atrium and ventricle, at least 2 chambers, along with this abnormal hepatic venous Doppler, then it's quite specific. It's 98% specificity. But if we encounter only either 1 chamber collapse or any abnormal venous flow, then its sensitivity decreases more than the specificity. Now, my question is, when is the atrium filled in cardiac tamponade? So that I have already explained, that the filling of atrium is impeded throughout the diastole in the cardiac tamponade. So the answer will be ventricular systole. So as it's a rapid fire, I'll come to the next pericardial pathology, which is constrictive pericarditis. So the important aspect in the constrictive pericarditis is there is reduction in the compliance of pericardium, and this reduction in the compliance of pericardium is also associated with dissociation of pressure transmission from intrathoracic to the cardiac chambers. And this, along with the fixed total cardiac volume, leads to the all feature of constrictive pericarditis. So basically, compression is maximum when pericardial volume is equal to cardiac volume. And contrary to tamponade, in constrictive pericarditis, this restriction occurs in the mid and late diastole. So the most of the filling occurs, or it is limited to the early period of diastole only. And similarly to the tamponade, there is increase in the end diastolic pressure in all chambers, and this end diastolic pressure is equal to pericardial pressure. As we all know that the pressure in the right side of heart is already low, that's why these effects are more pronounced on the right side of the heart. So the important aspect of constrictive pericarditis physiology is dissociation of thoracic and cardiac chamber pressure. So what happens during inspiration? That during inspiration, intrathoracic pressure decreases. And usually when there is normal pericardium, then this decrease in pulmonary circulation or thoracic pressure is reflected in intracardiac pressure also. But due to loss of elasticity of pericardium, this is not reflected in the intracardiac pressure. So during inspiration, when there is decreased pulmonary venous pressure, usually LV diastolic pressure also decreases in normal persons. But in constrictive pericarditis, there is no change in the LV diastolic pressure. This leads to reduced LV filling, and this further increase the preferential RV filling. So the characteristic feature is that chamber filling is dependent entirely on the pericardial elastance. So if there will be more chamber volume, then it will lead to more distension of pericardium, and that will further lead to decreased transmural pressure. So the same that I asked question in the tamponade section. Now similar question: what is the characteristic pattern of JVP in constrictive pericarditis? And when is the atrium filled in constrictive pericarditis? So I will give answer one by one. So first I am showing the JVP trace in the constrictive pericarditis. So the main interpretation of this trace is that first we have to look at the pressures. So the mean right atrial pressures are 20, which is quite elevated. So which is also a feature of constrictive pericarditis, that mean right atrial pressures are quite increased. And in difference with tamponade, there is both descents are present in the JVP, X descent and the Y descent, because the diastolic filling is restricted in the mid or late part of diastole only. That's why Y descent is present in the constrictive pericarditis, while it is absent in the tamponade, because in the tamponade there is impedance to chambers filling throughout the diastole. So this is usually known as the M or W pattern also, and it's given a name as Frederick sign also. And in hepatic vein Doppler, it will be similar like tamponade. There will be diastolic reversal, as we have seen in the tamponade also. But the main difference in the constrictive pericarditis and restrictive cardiomyopathy in hepatic vein Doppler is that the reversal is more pronounced in the expiratory phase of the respiration in the constrictive pericarditis, while it has more pronounced in the inspiration in restrictive cardiomyopathy. And there is a there is hemodynamic of early diastolic filling, which causes dip and plateau pattern or square root pattern, because the filling is limited to early diastolic period only. That's why it's rapid, and suddenly when pericardium reaches the pressures in the cardiac chamber and pericardium chamber equalizes, this leads to the abrupt halting of the late diastolic filling. And one important thing is LV rapid filling wave, which occurs due to accentuated filling of ventricle during early diastole. So in this slide on the left panel, we can see the normal filling pattern. So during normal filling pattern, there will be rapid filling wave, which will be followed by slow filling wave and diastasis. But in constrictive pericarditis, that rapid filling wave, which is usually 1 to 2 mm of Hg depression, but in this constrictive pericarditis, this rapid filling wave will be more than 7 mm of Hg, and after rapid filling wave, there is complete cessation of blood flow, and there is equalization of both LV and RV diastolic pressures also. So this leads to dip and early dip and plateau pattern or square root sign. Another important aspect of constrictive pericarditis hemodynamics is respiratory variation in right atrial pressure. Usually right atrial pressure decreases with inspiration. But in the constrictive pericarditis, right atrial pressure is rarely decreases more than 3 mm of Hg, and the decrease is usually limited to less than 5 mm of Hg only. As we can see, there are two traces. One is pulmonary capillary wedge pressure tracing. So pulmonary capillary wedge pressure is decreasing during the inspiration, and the mean PCWP during inspiration is less than 20, while right atrial pressure throughout the respiration, it remains stable. It's mostly more than 20 mm of Hg. So this occurs due to the dissociation between the intrathoracic pressure and intracardiac pressure, and this is the basis why Kussmaul sign is present in the constrictive pericarditis, because thick pericardium does not allow the intrathoracic pressure to the intracardiac chambers. So usually what happens during the inspiration on the JVP, that there is fall in the jugular venous pressure during the inspiration, because during inspiration decrease in the intrathoracic pressure will lead to increased venous return to the right side of the heart, and that will lead to decreased JVP. But as there is dissociation between intrathoracic and intracardiac pressure, SVC-RA pressures are high even during the inspiration, and along with that there is increased IVC flow that will lead to paradoxical rise in the jugular venous pressure during the inspiration. And apart from constrictive pericarditis, there are other causes of Kussmaul signs like RV infarction, severe RV failure, or in restrictive cardiomyopathy also we can observe the Kussmaul sign. So this is mitral inflow of a constrictive pericarditis patient, and in mitral inflow there will be reduction in the peak E velocity during the inspiration, and this reduction is more than 25%. And in the PC, pulmonary capillary wedge pressure and LV gradient, so during the inspiration in CCP, that gradient decreases, while it does not decrease during the inspiration in the restrictive cardiomyopathy, because there is no dissociation between intrathoracic and intracardiac pressure. Another important aspect is exaggerated ventricular interdependence, and it is also known as ventricular discordance, which is exclusively with the constrictive pericarditis, and it does not seen in the restrictive cardiomyopathy. So during inspiration, RV pressures are increased and LV pressure is decreased simultaneously. So this is known as ventricular discordance, and reverse happens during the expiration. During the expiration, RV pressures decreases while LV pressure increases. So this is quite specific to the constrictive pericarditis, that there we can observe the ventricular discordance. And we can calculate the RV or LV area by the RV pressures. We have to multiply the RV pressure to the systolic ejection fraction, by which we can calculate the RV or LV area. And if we take the proportion of RV and LV area in the inspiration and expiration, we can calculate the systolic area index, which is more than 1 in the constrictive pericarditis, while it is less than 0.7 in the restrictive cardiomyopathy. So these are the all criteria of all echo and hemodynamic criteria of the constrictive pericarditis. So there is one important thing is that there is increased EDP both in LV and RV, and there is minor difference in the both LV EDP and RV EDP, which is usually less than 5 mm of Hg. And RV and diastolic pressure also increases, and both RVSP and RVEDP are increased, but the increase in the RVEDP is quite prominent. That's why the ratio of both diastolic and systolic pressure is more than 1/3, and pulmonary artery systolic pressure increases, but it's less than 55, and LV rapid filling wave is more than 7, and respiratory change in RA pressure are less than 3 mm of Hg, and PCWP and LV gradient is more than 5, and systolic area index is more than 1.1. So these are, especially this interdependence and systolic area index, are quite highly sensitive as well as specific. Now another important aspect is ventricular septal shudder, which we can observe in the M mode due to the B2B diastolic septal motion, because there is paradoxical septal motion towards the LV of interventricular septum. Other Doppler findings are there is decrease in the aortic velocity as well as increase in the pulmonary artery velocity. So now I'm coming to the question, when is the atrium filled in constrictive pericarditis? Because the filling is impeded in the mid and late diastole only, so it's evident that atria is filled during systole as well as during early diastole. Now there is one important aspect is pulsus paradoxus. So what pulsus paradoxus is basically defined as exaggerated decrease in the systolic blood pressure, which is more than 10 mm of Hg during inspiration. Usually there is fall in systolic blood pressure during inspiration, but this fall is less than 10 mm of Hg. But in constrictive pericarditis, this fall is exaggerated. It's not pulsus paradoxus. Paradoxus is a misnomer. It's not a increase in the systolic blood pressure as it appears, but it's a exaggeration of the normal phenomena only. And this occurs because of this ventricular interdependence. Because of this ventricular interdependence, there is both bulging of interventricular septum, and there is simultaneously there is decreased filling of the LV, which leads to decreased stroke volume. So now I'll come to summarize this topic, I'll come to the conclusion that what are the similarities in the tamponade and CCP and what are the differences. So diastolic dysfunction preserves ventricular interaction and all cardiac chamber pressures are equal and pulmonary hypertension. So it's present in both CCP and tamponade. So what is the difference between CCP and tamponade from the hemodynamics aspect? So one is important in the JVP, that in JVP there will be no wide descent in the tamponade, and in the invasive hemodynamics there will be dip and plateau pattern in the CCP because of the all filling occurs during the early diastole, while it will be absent in the tamponade, and there will be inspiratory increase in the venous return in the cardiac tamponade, but it will be absent because of the dissociation of intrathoracic and cardiac chamber pressures, and increased venous return in the tamponade, while interdependence will be more in the tamponade. Another entity is effusive constrictive pericarditis. So effusive constrictive pericarditis usually diagnosed when we do pericardiocentesis for a pericardial effusion. So what happens in the effusive constrictive pericarditis, that even after pericardiocentesis, there are certain features which are still there, like there will be preserved wide descent or Kussmaul sign. So that indicates that apart from the effusion, there is constrictive part also is there. So this entity is called as effusive constrictive pericarditis, in which there will be overlapping feature of tamponade and constriction. Another differential diagnosis for constrictive pericarditis is restrictive cardiomyopathy. So in restrictive cardiomyopathy, important differentiating sign are pulmonary artery pressure will be higher than 50 mm of Hg, and there will be no gradient in the during expiration in PCWP and LV diastolic pressures. And the important thing is there will be concordant LV and RV pressure in both phases of respiration. So in inspiration, if right-sided pressure are decreasing, then left-sided pressure will also decrease. And LV rapid filling wave also will be less than 7 mm of Hg in restrictive cardiomyopathy. And apart from this, tissue Doppler velocity will be severely reduced in the restriction. And in hepatic vein imaging, as I have already told, that flow reversal will be during the inspiration, while in CCP, the flow reversal will be during the expiration. Now I'll come to my second topic, which is management of cyanotic spell. So what is a cyanotic spell? So cyanotic spell is also called as hypoxic spell or a TAT spell, and it's most common in the age group of 2 to 6 months, and usually these spells disappear by the age of 4 years, and they usually occur in the mildly desaturated child, not in the severely desaturated child. And iron deficiency is a precipitating factor for these spells. So a typical spell should be start with a precipitant. So precipitants for a spell is like fever, dehydration, or anemia, and usually they occur without any warning, and usually starts or precedes by crying or feeding or any bowel movement. And in these spells, there will be disappearance of the murmur, while cyanosis will be increased, and there will be increased breathing. And sometimes these spells may be accompanied with the seizure or syncope, or in rare cases, sometimes death also occur in this spell. So in this image, as we can see, that there is a bluish discoloration of the lips and the extremities. So this is what typically happens during a spell, that there is deepening of the cyanosis and there is increased respiratory pattern. So apart from these precipitants, which I have told, there sometimes it can be precipitated by catheterization or even exercise, because during catheterization, even child is having more anxiety and sometimes they can skip the medication or they might be dehydrated. These are the reasons why catheterization can precipitate a spell. So there are several mechanisms till now they have been proposed for hypoxic spells. None of them is quite complete, because every mechanism has certain limitations. So the first mechanism that was proposed was increase RVOT contraction, which leads to increase right to left shunt and decrease pulmonary blood flow, as is evident by angiographically also, and this will lead to decreased murmur. But there are limitations, like if the RVOT obstruction severity is the mechanism, then why spell occurs in the pulmonary atresia or in the ventricular septal defect, which is not explained by this mechanism. Then after this mechanism, another mechanism came, which is peripheral vasodilation. So peripheral vasodilation explains that it increases right to left shunt across the VSD and decreases pulmonary blood flow. And in certain procedures, like when the amyl nitrite was inhaled to a TOF child, it led to the reduction in the murmur and cyanosis was increased. So it was thought that the pulmonary peripheral vasodilation is the main mechanism behind the spells. But there are certain conditions during the spells, like there is no fall in the systolic blood pressure or even in the diastolic blood pressure, and there is no pulse pressure widening. So this is not being explained by the peripheral vasodilation also. Then another mechanism is that hyperapnea. Hyperapnea usually starts with the crying or the feeding. So this hyperapnea leads to increased systemic return with decreased pulmonary blood flow. So this will ultimately lead to increased right to left shunting, and this increased right to left shunting will further desaturate the child, and the further reduction in the arterial PO2 will initiate the respiratory, will lead to stimulation of respiratory center, and hyperapnea will again happen, and there will be a vicious cycle. But there are certain limitations to this mechanism also, that why if this is the reason that spell occurs, then why spell occurs in the morning hours only? Why they don't occur throughout the day? And as we all know that these receptor mechanisms are already been proved to be blunted in the cyanotic child. Then it becomes really difficult to explain that why whether this hyperapnea is the only reason why cyanotic spell occurs. Then another mechanism which is proposed by Dr. Kothari from AIIMS, that the reason why spell occurs is the stimulation of the mechanoreceptors. This try to explain most of the things, like these stimulation of mechanoreceptor leads to the increased RV contractility along with the decrease in the cavity of right ventricle, and that will lead to hyperventilation, peripheral vasodilation, and in this condition there will be no decrease in the heart rate. So that will lead to increase right to left shunt and the spell ensues. So there are several mechanisms for spells, like increase in fundibular contractility, peripheral vasodilation, hyperapnea, and stimulation of RV mechanoreceptors. So what are the clinical features? As I have already told, that breathing becomes laborious and both intensity and the deep breathing will ensue, and apart from this, anxiety and hyperapnea will lead to increase in the right to left shunt, and that will deepen the cyanosis, and there will be tachycardia. And the important thing is that the systolic murmur will decrease or disappear. So usually the spell lasts for 1 to 5 minutes, but in certain conditions it may last up to half an hour or sometimes lead to seizure and death. So there are 3 important things for cyanotic spell management. One is the general measures, and second is medication, and third is the surgical part. So for general measures, we have to look for the precipitants like anemia, dehydration, infection. We have to comfort the child, and we should not force oxygen to the child. So usually most of the episodes are self-terminating, and they usually respond to simple measures. And for management, our target should be to control the heart rate, to control the catecholamine surge, and to control the vasodilation, hyperapnea, and infundibular contraction. So first and foremost important thing to control the cyanotic spell is to administer the oxygen and to place the child in the knee chest position. There are several adaptation of knee and chest positions. Suppose patient is lying supine, then we can fold the knees and try to keep the knees as close to the thoracic cavity as possible. And if child is in the lap of mother, then she can fold the knees and keep the child in lap only, and that will also help to mitigate the cyanotic spell. Apart from knee chest position, we have to administer IV fluid, normal saline at the rate of 10 to 20 ml per kg over half an hour. But during fluid administration, we have to be careful not to infuse excessive fluid, because that can lead to pulmonary and cerebral edema. Apart from fluid, we can give morphine, which has pleiotropic effects, like it decreases the sympathetic drive and it decreases vascular resistance. That will break the vicious cycle of hyperapnea. And bicarbonate can be given because they correct the acidosis. And acidosis, which has a respiratory center stimulating effect, so it eliminates that effect, and it also diminishes the increase in the pulmonary vascular resistance. Beta blockers are the mainstay of the cyanotic spell treatment, and they are being used for the prevention of spells also. They have multiple actions like antiarrhythmic effect, they decrease the heart rate, they increase systemic vascular resistance. So metoprolol in the dose of 0.1 mg per kg and propranolol, similar dosage 0.1 to 0.0 mg per kg, will decrease the heart rate and will relieve the infundibular spasm. Apart from them, esmolol in the dose of 500 microgram per kg over 1 minute, followed by 50 to 300 microgram per kg per minute can be given. And for prophylactic, oral propranolol in the dose of 2 to 6 mg per kg can be given. So phenylephrine, which acts as alpha adrenergic receptor stimulator, and methoxamine can be given, and we have to titrate the dose according to the increase in the blood pressure by 20%. Sometimes spells don't respond to these things, then we have to administer anesthesia also in the form of ketamine, and this act as a sedative as well as peripheral vasoconstrictor that decrease the right to left shunt. Nowadays, intranasal therapy in the form of fentanyl and midazolam also being given during the spell. The main advantage of intranasal therapy is that intranasal mucosa is highly vascularized. And second importance is that if we have to give the drug by intravenous route, then it's very painful, and it can stimulate the sympathetic system, and it will increase the anxiety and pain of the child. So that will further precipitate the spell. So the intranasal drugs can help in combating that problem. And dexmedetomidine is used in place of morphine because it has minimal respiratory depression. The actions are similar, but it has minimal respiratory depression. Apart from the medication, in the surgery part, we have definitive surgery as well as palliative interventions. So palliative interventions are usually performed when single stage surgery is not possible. There are certain conditions like babies very small, or pulmonary arteries are very small, and baby is very sick to undergo a surgery. So in those conditions, we have to perform palliative intervention. So in the form of, initially the palliative intervention were done by surgeons only in the form of surgical shunts, but nowadays percutaneous palliative intervention in the form of RVOT stent or PDA stenting or RVOT balloon dilation are also being performed. So shunt surgery was basically done mainly by Bella-Locke and Toshing, and it's known as Bella-Locke Toshing shunt. The difference between classic and modified shunt is that in classic there is end-to-side anastomosis, while in modified there is side-to-side graft. And in central shunt, there are two types of central shunts. If we apply from descending aorta to LPA, then it's known as port shunt. And if we apply shunt from ascending aorta to RPA, then it's called as Watterson shunt. So what are the advantages of these shunts and what are the disadvantages? So these BT shunt, modified BT shunt is having advantage like there is lateral incision only and it's very easy to take down. And it whenever there is increased flow, the artery also increases with the age and it augments pulmonary arteries. And the disadvantages are like it damages the phrenic nerve and it increases the pulmonary blood flow. And in 20% cases, there may be congestive heart failure. So nowadays, RVOT stenting is also done, which is a percutaneous procedure. And the main indication of RVOT stenting is when we can't perform the surgery, like in small babies or when there are too many comorbidities or pulmonary artery having stenosis or small in caliber. So it is being done as a palliative procedure. And what is the advantage of RVOT stenting? That it causes symmetric growth of both pulmonary arteries, and there is decreased morbidity as compared to the surgical shunt. But the disadvantages are there may be stent fracture, migration, or thrombosis, and sometimes retained stent can be a focus for arrhythmia or infections. Nowadays, new entity is PDA stenting, which is a attractive alternative to the conventional surgery because it avoids thoracotomy and it can be done when child is very sick and surgery is completely out. So nowadays coronary stent are being used for PDA stenting and it's done mainly in the neonatal period. Early studies have during early studies, there were discouraging results from PDA stenting, but nowadays there are promising results from PDA stenting also. So, but it's there are certain contraindications for PDA stenting, like it's contraindicated in ostial pulmonary artery stenosis. It's very difficult to perform in tortuous anatomy, and it's basically done in duct-dependent cyanotic heart disease only. And if it's not an option if duct is closed. So this is how the PDA stenting is being performed. The important thing is how we size the stent for PDA stenting. So length we usually keep for PDA stent is usually 1 to 2 mm more than PDA length because it's expected to shorten around 15 to 20%. So we have to keep the stent length 15 to 20% longer than the PDA. And diameter is usually similar to the weight of the child. Whatever the weight of child is usually the diameter of the stent. And it's very wise to keep the wire across the duct after placing the stent for at least 15 minutes because sometimes there is acute thrombosis or stent migration or ductal spasm. These are the complications during the PDA stenting. Definitive surgery is always a good option. The only disadvantage with the definitive surgery is that there might be brain injury because neonatal brain is more prone for hypoxic injury. Otherwise, it decreases the RV hypertrophy. It's a very physiological thing. It tries to avoid the LV volume overload, which occurs due to palliative shunts, and there is definitive reduction in the arrhythmias with the definitive surgery. So what are the prevention measures for spells? We have to educate the parents that they should adopt the squatting timely so that spell may be aborted in the time, or beta blocker in the form of propranolol can be given for prevention, and we have to correct the anemia and try to avoid all the precipitating factors like fever, dehydration. So what advice a fellow should give a patient of cyanotic spell? That he should enter the precipitating cause, what's the neurological status, what medications were used for management of spells, and three things. One is beta blocker, iron supplement, or deworming, as the main reason of iron deficiency in developing countries, the worm infection, and he or she should tell the spell position. Now, the next topic is the role of natriuretic peptide in the valvular aortic stenosis. I've kept it very small because it's a topic less studied, but it's a thing which can be potentially investigated in the valvular AS. So because we have to rely on the patient reported symptoms for valvular AS, which can be misleading because most of the patients are elderly and they can adjust their lifestyle to mitigate the symptoms. And sometimes patient may not notify the onset of symptoms. And if there are too many comorbidities, then it's very difficult to distinguish whether the symptoms are due to lung disease or something else. So in aortic stenosis, the importance of BNP is that its elevation usually occurs before the symptoms develop. So natriuretic peptide level is correlated with LV hypertrophy, severity of aortic stenosis, onset of symptoms, even LV function, and mortality also. So one study done by Rajani et al. So they followed 65 asymptomatic patients with area less than 1.5, and they have shown that if BNP level is more than 58, then it's 80% sensitive to for early recognition of the symptoms. And Monin JL, they developed a score, and the cutoff value of the score was 16, and the score is basically peak velocity square plus BNP into 1.5 plus we have to add 1.5 if there is female. So they have actually calculated the 2 years event rate. So when the score value was more than 16, then there was definitely increased event rate in that group. So in the guideline also, surgical aortic valve replacement is indicated when we have stage C aortic stenosis without symptoms and we have BNP more than 3 times. So which is indicator of rapid disease progression. So if BNP levels are more than 300 picogram per ml, it's associated with increased 5-year risk of AS related events. Thank you.
Thank you, Satyaveer. It's a really nice, lucid presentation on all the 3 topics. I think you have done justice to what has been given to you.
Although, sir, the topics were quite broad, they were very difficult to make them in the rapid fire session because every topic is quite vast. So I tried to cover each and everything. So pardon me if I have left anything.
Absolutely, absolutely. You have not left anything. I think you have done total justice to the pericardial disease as well as cyanotic spell.
Yeah, Satyaveer, nicely covered. I think you covered comprehensively all the 3 topics. Actually, sometimes failure to understand the mechanism sometimes makes us difficult to remember the flow reversals. I don't know could you look up why it is in inspiration? CCP it is an expiratory flow reversal in hepatic veins. and in RCM it is more in inspiration.
So that basically due to the discordance, due to the dissociation of intrathoracic pressure and the intracardiac pressures that don't occur in the restrictive cardiomyopathy. So this respiratory variation is basically due to when there is inspiration, there is fall in the intrathoracic pressures, but in the CCP, that fall in the intrathoracic pressure will not transmit to the intracardiac pressures. And simultaneously, there will be reduced LV filling. So that's why this reversal occurs in the constrictive pericarditis.
Again, about cyanotics, well, no, I think one of the popular theories is this vulnerable respiratory center. But somehow I think in the mechanism, this vulnerable respiratory center, I thought was not mentioned. So, do you think it is important?
Yeah. Sir, vulnerable respiratory center is also a mechanism, but that I tried to cover in the hyperapnea only. Because in the cyanotic child also, there is some theories that the hypoxia blunts that vulnerability of the respiratory center, which is more pronounced in the cyanotic heart disease. That's why the mechanoreceptor theory is more acceptable, that spell occur during the morning time or they don't occur during the whole day.
Then the reason why this spell disappears over a period of time, if it's only mechanoreceptors, then why it disappears over a period of time, the RB still remains hypertrophied, then will be little. So probably they say the respiratory center matures, people learn compensatory mechanism. So many things they used to explain. Yeah.
It's actually unanswered, because some say that the by growing age that stimulation of mechanoreceptors is less, or this is the reason they give that why it disappears, but it still remains unanswered and it should be investigated.
Yeah. BNP level, keeping like values like 50, 60 and all are little dubious values, but should we not keep it a higher cutoffs for to say, this is really, responsible? Should you?
I think 300 would be better, because in first study they kept the value quite low. 50 is quite low, and in another study it has shown that if BNP level is more than 300, then the event rate is 5 times higher. So I think there is no consensus what should be the value. There should be more RCTs on that, so that we can have a exact cutoff value to define that.
Thank you. I think it was any other questions, Girish? I think it was a terrific presentation about it, and this is a first great initiative. Satyaveer, thank you so much again. We'll be loading on our YouTube channel. You guys can just pick these presentations again and listen to them. They were very relevant. There are many new points to be discussed, to be really learned about, and it was a great recapitulation of very well-known facts also. So thank you, Satyaveer. Thank you, Sumo. Thank you, Girish, and thank you everyone for joining us today. And we'll be the full small topics. Thank you, and have a great day.
Thank you very much, sir.
Thank you so much.
Thank you, Satyaveer. Thank you, and good night.
Good night.